households are doing well. I'd like to thank April and the team, and I want to thank all of you all for the opportunity to speak this morning. Thanks for coming out early this morning to hear me speak. So the title of my presentation is Penile Implant Surgery, Before, During, and After. Most penile implants are put in for erectile dysfunction. Next slide, please. Next slide, please.
Sorry.
Erectile dysfunction is the inability to achieve and maintain an erection which is satisfactory for sexual intercourse. Next slide, please. Now, erectile dysfunction is different from premature ejaculation or problems with desire. It can affect men and women differently. For men, some men have a feeling of depression or distress or withdrawal from their partner, shame, disappointment, frustration. Some men even question their manhood. Next slide. Spouses can be affected in terms of sometimes feeling guilty when there's erectile dysfunction, or unattractive, feeling lonely, unwanted. There can be a loss of attraction or intimacy in the relationship. Next slide, please. About 150 million men in the world have erectile dysfunction, and here in America, 30 million men have erectile dysfunction. When we look at middle-aged men, about half of the men have problems with erections. Next slide, please. Diabetes is the most common reason for men having difficulty obtaining an erection. Diabetes can affect the nerves and blood vessels within the penis. Other blood vessel diseases like high blood pressure or hardening of the arteries or high cholesterol or triglyceride can affect erectile dysfunction. Nervous system diseases like stroke or spinal cord injury can contribute to the same. Pelvic surgery, we're doing prostate surgery, bladder surgery, rectal surgery, it can contribute to the same. I'll explain this a little bit more later. In 5% of cases, a gentleman having low testosterone can lead to problems with erections. Psychological problems, for example, depression or anxiety, sometimes guilt can affect a man's performance. Side effects of medications, for example, most commonly side effects from high blood pressure medications can contribute to the same. Lifestyle factors like abuse of alcohol and drugs may contribute also. Smoking can damage penile blood vessels. Priapism, which means a prolonged erection more than 4 hours, can lead to the same. And penile scarring diseases, something known as Peyronie's disease, can contribute likewise. In 80 to 90% of cases, when the gentleman has difficulty obtaining an erection, it's usually because of a medical problem. In 10 to 20% of cases, it may be psychologic. In some men, it's a combination of both. So I want to just speak about some basic anatomy related to sexuality. This is the urinary bladder, which stores the urine. The urine flows through the urethra. The testicles make 100% of the sperm, but very little of the semen juice. 1/3 of the semen is made by this gland here, the prostate gland. It's a gland that encircles the urethra. It wraps around it kind of like a donut. So 1/3 of the semen juice is manufactured here in the prostate gland. Most semen juice, in other words, the ejaculate, most of it's produced by the seminal vesicles, which are sandwiched between the bladder and the rectum. Now, I like to think of the penis as having 3 spaces. One space is the canal, the urethra, and then we have 2 spaces inside of the urethra called the corpora cavernosa. These are spaces that fill up with blood during lovemaking. I like to refer to these as the inner tubes of the penis. If we have a bicycle tire, there's an inner tube inside of the tire. Well, in the course of an erection, blood flows into these spaces known as the corpora cavernosa. Next slide, please. We have some important nerves in the pelvis that are important for erections as well. So if you can imagine, I'm sorry, it's not projecting so well. We have our brain. The brain sends nerves down the spinal cord, and then in the pelvis, there are these nerves known as the cavernosal nerves. They come down at the bottom of the pelvis. They hug the prostate as they travel down here toward the penis. Sometimes these nerves can be affected with pelvic surgery or radiation therapy and affect the gentleman's ability to have an erection. Next slide, please. Looking inside the penis, again, 3 chambers inside the penis. There's the paired corpora cavernosa, and there's the urethra. I think of the corpora cavernosa of the inner tubes of the penis during lovemaking. These fill up with blood. Next slide, please. If one thinks about the process of inflating a flat bicycle tire, one might be able to understand erections and also the concepts behind an inflatable penile implant. So simply stated, when a person is pumping up a bicycle tire that's flat, there's air in the atmosphere. Air in the atmosphere. A person then uses a pump, and the pump takes the air out of the atmosphere through the tubing. The air is put into the inner tube of the tire. The tire inflates, and this could be used for a bicycle ride. So if the pump is like the heart, and these are blood vessels, and the tire is the penis, one can think about a penile erection. So I'm going to go back to this example later on in the talk. But having an erection is very similar to pumping up a bicycle tire. Next slide, please. If we look at the penis and slice it, we can see the chambers of the penis. When an erection takes place, when we go from a flaccid or soft penis to an erect penis, blood flows into the penis, the chambers expand, and veins that allow blood to escape from the penis close up so that an erection is maintained. Next slide, please. Well, 30 million men have problems with erections. Here in America, we have treatment options. We have pills like Viagra. We have penile injections. We have a vacuum erection device. We have a suppository that can be placed inside the penis known as mousse. We have penile implant surgery, and in some cases, we replace a man who has low testosterone with testosterone replacement. Next slide, please. So this is Viagra, a pill to improve erections that works in about 60% of men. It improves penile blood flow. Next slide, please. We have penile injections. This is where a diabetic needle syringe is utilized to improve erections. Next slide, please. During penile injections, a gentleman will use this syringe, place medicine directly into the corpora cavernosa. The medication causes blood vessels to open up and dilate so that blood rushes into the penis. Next slide, please.
How long does that last for? Like if they did it so long?
So most men, the erection lasts about an hour. It can be less, it can be more. The medication can be titrated or kind of altered.
So they have to do it to themselves, basically?
Exactly,
Oh, wow.
exactly. Sometimes with couples.
Right, spouses do it.
Exactly, exactly. Mousse is a suppository placed inside of the penis to improve penile erections. The vacuum erection device is another option to improve erections. This is where a gentleman will put a cylinder around the penis, and the cylinder causes a suction or a vacuum effect so that blood rushes into the penis to fill up the inner tubes so that a man can have an erection. After the vacuum device is placed, a rubber band is placed at the base of the penis to maintain the erection. And finally, we have penile implants, where we do surgery to allow a man to have an erection. And this will be the topic of today, penile implants. We have 2 types of penile implants. We have the non-inflatable, this is also known as the malleable or semi-rigid penile implant. This is where we have 2 rods that are firm but flexible. Next slide, please. With a malleable penile implant, we put the rods within the penis, inside of the corpora cavernosa, the inner tubes of the penis. This picture, I want to say, shows normal penile anatomy. A man's penis does not begin right here at the front of the abdominal wall. The inner tubes actually go deeper into the body, near the pubic bone, real close to the prostate gland here. Next slide, please. We have the inflatable penile implant, a device that is placed where a man can pump up the device, like pumping up a bicycle tire, and then deflate the device. So this allows a man to have a rigid erection and also have a soft or flaccid erection. And the inflatable penile implant, when it's placed, has 2 cylinders put inside of the inner tubes, the corpora cavernosa. There's a pump, kind of like a bicycle pump here in the scrotal sac. And then we have a reservoir, which is placed behind the pubic bone, right next to the urinary bladder. Next slide, please. I'll pass these around. So with the semi-rigid penile implant, we have 2 firm rods placed inside of the penis. These are firm but bendable. And we custom fit each gentleman. I'd like to pass this around to the group. And then we have the inflatable penile implant. Two cylinders inside the penis, a pump in the scrotal sac, a reservoir. So when a gentleman wants to have an erection, he will reach down, instead of touching his testicles, he will squeeze the pump. Each time he squeezes the pump, a half teaspoon of liquid, we put salt water in here, saline, the same type of liquid that's inside the IV bag, and the gentleman will pump. Most men need to pump 10 to 25 times to achieve an erection. And once this is inflated,
Does it stay attached like the whole time?
yes, it stays erect and firm until a gentleman lets it down.
But the pump part stays with them the whole time?
Yes, everything's internal.
It's in the scrotum.
I had one yesterday, but I didn't get the discharge in, so I didn't like see very much. I didn't do the discharge instruction.
Sure.
So I was kind of wondering.
It's in the scrotum, right?
It's inside the scrotum. Can we go back?
Yeah, right there.
So when this is placed, everything's internal, and the cylinders inside the penis. There's a pump in the scrotum internally, and this is the reservoir. So after making love, a gentleman will push this deflation button, holding it down for 4 seconds, and then squeeze the cylinders or squeeze the penis like emptying out toothpaste or an air mattress, putting pressure, and that then transfers the water back to the reservoir. So this works on the principle of water transfer. I'd like to pass this around. Thank you very much. Let's advance the slide. We're going to show some intraoperative pictures in a moment. So again, just to conceptualize, if you think about that example of pumping up the bicycle tire, when we pump up a bicycle tire, there's air in the atmosphere. Well, with the penile implant, instead of air, we put salt water inside of the reservoir. And when it's time to make love, a gentleman or spouse will squeeze the pump. And that's going to transfer the salt water through the system here, through the pump, into the cylinders of the penis. And we empty out the reservoir and the penis becomes erect. Next slide, please. So I want to, okay, thank you.
I'm sorry.
Am I doing okay on time?
Yes, you're fine.
Okay, thank you. So, when patients make the decision to have a penile implant installed, in many cases they've tried other treatment options, pills or the penile injections, or they may have tried the mousse or the vacuum device. And they finally made a decision to have a penile implant installed. Upon arrival, we want to make sure that the urine culture is negative. We don't like to operate in the setting of active infections. Next slide, please. To prevent a penile implant infection, which occurs in about 2% of cases, it's important to know what type of bacteria or fungi produce implant infections. And that's things, bacteria that can cause urinary tract infections: E. coli, Pseudomonas, Enterococcus, Staph aureus, Staph epidermidis, or in some cases Candida. In our patients with diabetes, we're finding more and more patients may have fungal infections. Typically, we ask that vancomycin and gentamicin be given prior to performing surgery. And from our medical society, the American Urologic Association, there's a statement. And so back in 2008, I'm going to read it verbatim. The 2008 AUA best practice policy on the use of IV antibiotics for broad spectrum coverage prior to penile prosthesis surgery recommends use of vancomycin or a first or second generation cephalosporin, things like Rocephin or ceftazidime. I typically myself would substitute Zosyn in that case, as well as aminoglycoside, for in other words, gentamicin, 1 hour before surgery and up to 24 hours after surgery. So that's coming from our medical society to give vancomycin and gentamicin. And it's important to give it 1 hour before incision, vancomycin that is. Next slide, please. How come? The timing of antibiotic administration, I've taken this verbatim, may vary, but the goal of administering preoperative systematic prophylactic antibiotics is to have the concentration in the tissues at its highest at the start and during surgery. So we like the tissues to be well saturated with vancomycin when we're making an incision and during the surgery. So when a gentleman presents to the preoperative area, a lot of gentlemen, they've been through a lot emotionally, and they may have tried certain things out to improve their erection. So in the preoperative area, some of the gentlemen are very excited. Some may be embarrassed. Sometimes there may be some surprise. There's maybe 10 to 20% of gentlemen who don't share with their spouse that they're having the surgery performed, or their family. Sometimes the spouse may be surprised that a penile implant's put in. I've gone out to the recovery room to speak with family. I'm talking about the spouse, and the spouse asked me, well, doc, did you remove all the cancer? Or how'd the biopsy go? So these are some things just to be aware of. Some gentlemen are embarrassed or excited. There could be a range of emotions that people feel preoperatively. Next slide, please. We recommend that our patients do not shave prior to going into the operating room. So we don't ask that nurses shave beforehand in the preoperative area like other operations, and we certainly discourage our patients to not shave, because shaving can cut the skin and let bacteria in. Next slide, please. So during the course of the operation, we shave the patients. Next slide. We use Preop, which is, you might see in our patients, kind of the tan brown antiseptic. Our studies have shown that Preop kills more bacteria on the skin than betadine. Next slide, please. We place a Foley catheter. We do this to help us identify the urethra during this surgery, and also to empty the bladder so that when we put the reservoir in the pelvis, there's space. Next slide. And we inject a long-acting Marcaine, a numbing medicine solution, at the base of the penis. Our hope is that when patients arrive in the recovery room, they have zero pain, and hopefully for a day or two afterwards, they'll be pain-free. So during the surgery, this is the penis here. We make an incision in the upper part of the scrotum. Next slide. That incision then allows us to see the spaces of the penis. So you can see this structure here, the urethra, and then we have the inner tubes, the corpora cavernosa. We then make a small incision in the inner tubes, the corpora cavernosum. Next slide, please. We then use what's called Hager dilators, which are these steel rods, to create a space in the penis. When penile implant surgery is performed, we don't remove any tissues. Nothing's removed. This system's added to the body. Nothing's taken away. So we go ahead and we dilate the penis. Next slide, please. And then once we've created a space, we measure a man's penis. So I apologize, my pointer's not the strongest, but we measure the penis going out toward the tip and then deeper into the body, so that we can measure the size of a gentleman's penis, so we can custom fit each gentleman with the penile implant. We then put the implant in, and when we put the implant in, the implant is coated with a orange, tan, I'm sorry, I'm not good with colors, a solution substance called inhibizone, which is a coating of bacteria, minocycline and rifampin. This antibiotic coating leaks out into the tissues to lower the chances of penile implant infection. Next slide, please. And then we position the implant in the body as pictured. Everything is placed internally. Next slide, please. You'll often see that we place a bandage, which we call a mummy wrap, around the penis. So we wrap the penis up, and that's by design. We do that to minimize bleeding within the tissues and to minimize swelling. Oftentimes, at the conclusion of the case, we remove the Foley catheter. Next slide, please. Our patients oftentimes arrive to the recovery room with a partial erection, and that's by design. We found that if we leave the implant partially inflated in the early healing phase, a gentleman will have a longer penis than otherwise. It also helps to minimize bleeding by having it partially erect, bleeding within. Next slide, please. So the patients had surgery and arrived to the recovery room. And again, I just want to take a moment to say thank you. Thank you for the years of service and taking care of our patients. Thank you to you all. But there's some things we look for. We've been removing the catheter prior to the patients waking up from surgery. One thing we want to make sure is that a patient not have urinary retention. Urinary retention occurs in 4% of patients. So most patients are not going to have urinary retention, but that's what we look out for. Next slide, please. Hematoma formation. So the mummy wrap is placed to prevent this, either a scrotal hematoma or a penile hematoma. Thankfully, we're not seeing that very commonly. Next slide, please. I've never seen a case of this, but I've read about it, so this is something to be aware of. It's very rare. I've never seen it, so I wanted to just show a hand because I've never seen it in the penis personally. But we have something called gland ischemia, poor tissue flow to the penis, leading to necrosis or death of tissue. So if you can imagine a hand getting poor blood flow, it can have a dusky appearance. If the head of the penis appears dusky, particularly later on in the day or the next day, then that's a dangerous sign because the head of the penis, the glands can necrose or die, just like there can be a necrotic finger. So the patient goes home. We typically will administer antibiotics. Our scientific evidence show that postoperative antibiotics don't reduce penile implant infection, but most surgeons give patients antibiotics. Pain relievers, ice is recommended once the mummy wrap is removed. We recommend one night strain after the surgery to prevent migration of the reservoir that's placed. We want that to heal in proper position. Next slide, please. Our patients are recommended to position their penis upward in the early healing period to prevent downward erection. When the implant's put inside the body, it's very faint here, but there's a capsule that forms around the implant in the body. And it's better for that capsule to heal more upward than downward, so that when a gentleman pumps the device, he doesn't have a downward erection. The pump in the scrotum, we like it to remain in the lower part of the scrotum. So oftentimes our patients are asked in the early period to push the scrotal pump down so that it does not ride up toward the base of the penis. So sometimes the surgeon was asked, please encourage the patients, or write on discharge summary, encourage the patients to push the pump downward toward the feet. Next slide, please. And then we see the patient back in our office. We check out the wound. We instruct the patient and their spouse how to operate the device. Most couples are sexually active within 2 months. Very rarely it's 1 week, and very rarely maybe 6 months. 90% of people are satisfied. Thank you. So just real briefly, penile implants have been around nearly 50 years, believe it or not, 50 years. Here, we've been doing penile implants. Our colleagues back in 2014, we formed what's called the prostatic urology team, and our goal was to help patients recover lost sexual and urinary function. And this is including doing surgery, penile implants, male slings, and artificial urinary sphincters. These are surgeries designed to help urinary leakage. Next slide, please. This kind of shows you our surgery counts pre-COVID. Next slide, please. These are the members of the team here at Fontana. Next slide, please. I want to say thank you. Thank you.
Thank you.
Quick question, it was standard in the past that you kept your patients overnight.
Yes.
Is there a reason why you're not doing that anymore? Are the post-operative complications really low? Are you not using antibiotics for that 24-hour period?
So a few things happen to make us send patients home. Number one, I would say that Exparil, the long-acting numbing medicine, came about. Patients were more comfortable. We found that patients oftentimes, when they were admitted to the hospital, didn't have too much pain, and one of their chief complaints in the hospital was that the Foley catheter was bothering them. So we started to learn about the world experience of penile implant surgery with utilizing Marcaine for good pain, Exparil for good pain relief, and then realizing that urinary retention is so rare. We just started in 2016 to start, I'll use the word loosely, experiment with patients going home. We found that they did well. Some patients actually preferred to be at home because some of the gentlemen are embarrassed, and we felt that patients did well without increased complications. And then when COVID came, it just became more of a standard practice. Patients desired it. It seemed to be effective. It also freed up bed space in the hospital and lowered costs.
Any other
How long does the mommy rub stay?
We recommend 1 day. So 1 day, just 1 day only.
So they go home with it?
Yes. Yeah, 1 day.
Any other questions for Dr. Lawrence?
And
I
are
know-
you, oh, sorry, go
And
ahead.
I know the mommy wrap, you give them direction how to remove it.
Yes, yes. What I do personally, I wrap it, and then I put a piece of tape. You may have seen my tape, and I usually get a marking pin, and I mark arrows. And I tell the family, follow the arrows in terms of taking the tape and unwrapping it in the direction of the arrows.
So just confirm, so post-op, we're looking for retention and then any kind of, like necrotic, like blue on the tip, and then any, like hematoma around the area. Those are the three things we're looking for. Okay.
Yes, yes. Couple other things. When we perform surgery, we put a hook, like a fish hook, in the urethra opening.
Okay.
Just like just like a fish bit down on the hook. So we put that in the head of the penis to pull it outward for retraction during surgery. Sometimes that causes a little bleeding from the urethra opening from the tip. I wouldn't recommend to be overly alarmed about that unless it was just continuously oozing.
Right.
So we would sometimes be concerned if there was ongoing bleeding from the urethra opening pouring out. That may be a sign of urethral injury during the time of the implant placement. We do place a Foley catheter, so sometimes there can be blood in the urine. We'd be really concerned if there was heavy bleeding with blood clot formation. That might suggest a bladder injury at the time of reservoir placement.
Okay.
Thankfully, these things don't happen too commonly. The glands necrosis or ischemia, I've never seen it.
Okay.
Never seen that, but if you do see it, please let us know.
Okay.
Hi there.
Hi, I'm just wondering, does it hurt when they pump? Because it's in the scrotum?
Initially in the healing phase, but it will get to a point where there's no pain.
Okay,
Yes.
thank you.
Oh, you're very welcome. Yes.
sometimes, okay, not sometimes, but we discharge the patient with, a pump. What's that for, if it's internal? Is
Oh,
that
yes.
in the keychain? Or
So
just-
the manufacturer has an envelope, and it has a pump, and it has in the envelope also directions how to pump up the device. So it's in the color of the inhibizone, the orange coating, that pump, and that's just a model that patients can practice with.
Oh, I
So
see.
they can start practicing it and feeling it, and it helps them to, when it's time to actually pump it on themselves, they have a model that they can practice with, or the spouse can practice with. It also kind of mimics how it feels in the body in terms of the texture.
Any other questions? Alright. Well, thank you, Dr. Lawrence. That is very, a lot of information for us, and I think it will really help us with taking care of our patients pre-op and post-op.
Yeah.
Yeah. Alright.
Well, thank you, thank you very much, thank you. Okay, thank you to you all, thank you, thank you.
Alright, and thank you for coming in at 6 o'clock in the morning. Actually, he was here earlier, probably 20 minutes earlier, but thank you.
Thank you, thank you. Everybody have a great day.